And we're going to start off with Dr. Katherine Tuttle. Now, I've been trying to get Katherine here for a while and finally managed to reel her in and get her to an At the Limits meeting. She is going to, she's a woman who's been embedded in the field that is actually central to what we're all here for, this crossover area between diabetes and cardiovascular medicine and nephrology. One of the reasons she's so adept at handling this is that I'm delighted to see that she's did a fellowship at Washington University, St. Louis, Missouri, where I also spent 2.5 very happy years. Slightly ahead of you, actually, Kathy, but never mind, we'll let that one pass. And she's going to talk about crosstalk between kidney and the circulation in diabetes. Kathy.
Okay, thank you very much for the introduction. And I'd also like to thank the organizers and the sponsors for the opportunity to be here. Also, the previous speakers who really provided much of the background information to set the stage for this talk, that it will take us a little deeper into the kidney. Here are my disclosures. So my objectives in this talk are to assess the major risks for patients with diabetes and chronic kidney disease, and then to interpret shortfalls of traditional anti-hyperglycemic treatments, and then compare the effects of newer agents on the kidney and the heart, and then to begin to integrate mechanisms with new therapeutic approaches. So in addition to nephrology, I'm also an endocrinologist. That's what I trained in at WashU, and really focused on diabetes. So I look at this from a very broad view, and I'd like to start with a broad view. That is that diabetes is now a global emergency. And in fact, despite what we know about diabetes prevention, there's no evidence that has been translated in any meaningful way to impact diabetes prevalence in any region of the world. And worldwide, we're projecting from 2017 a 48% increase to 629 million by the year 2045. And I drew a box around these countries south of the equator where we see increases that exceed 50%, in some cases in Africa, 156% increase projected. The Western Pacific doesn't see as much of an increase, but look at this, nearly 159 million now, up to 183 million in 2045. So certainly diabetes prevention should be our goal, but the truth is, while we're working on that, we're going to be taking care of many people with diabetes and diabetic complications for the foreseeable future, and certainly for most of our lifetimes. I'd like to now dial into the very seriousness of developing chronic kidney disease and diabetes. It is still common. It occurs in about 1/3 of people with type 1, 40% overall in type 2, but in non-white populations, this typically exceeds 50%. Diabetes is now responsible for nearly half of all cases of CKD and end-stage kidney disease worldwide. And in American patients with end-stage kidney disease, it's prevalent in 66 to 86%. The reason for this is that many people develop diabetes after end-stage kidney disease, particularly after transplantation, new-onset diabetes. And also remember that diabetes and chronic kidney disease are both common conditions, and people with diabetes could have another form of chronic kidney disease. So I attend in both the nephrology and endocrine clinics, and here's a sobering point. We proportionally see more people with diabetes in the renal clinic than we do in the endocrine clinic. Face that reality, folks. Also, almost all of the cardiovascular risk in diabetes is present in the group with CKD. And in fact, I'd like to thank, I believe, the first speaker, Dr. Leroux, yesterday, who showed a paper from our group. Marian F. Karim was the first author, where we showed that almost all the excess cardiovascular risk was found in people with albuminuria, low GFR, or both, with a graded increase in risk across those strata. Now, however, what I want to talk about are the risks. What happens to people who develop chronic kidney disease and diabetes? Well, the sad truth is that only 10% survive to end-stage kidney disease, a fact that we rarely talk about. That means progressing to needing renal replacement therapy, and that's because of the competing risk of death. 90% will die. About half of those deaths are cardiovascular causes, and about 1/3 are infections, which I won't cover today, but we will dial into the cardiovascular risks. What can we do about this now that we've sort of rung the alarm bell? Well, our first line of defense traditionally has been intensive glycemic control. And certainly, it prevents CKD when initiated early in either type 1 or type 2 diabetes. The benefits take about a decade to appear, and then they accrue over subsequent decades. However, when initiated in long-term type 2 diabetes, CKD onset and progression are largely not averted. And when we look at the cardiovascular outcomes, and this example from the ACCORD study, which is the large US study done of intensive glycemic control, actually in the subgroup who had CKD. And by the way, they tried to exclude people with CKD, so the ones who snuck in had very mild CKD. Nearly 70% only had microalbuminuria, and only 22% had a GFR less than 60. Very early CKD. But when we look at survival in the CKD group was significantly reduced, not equal, lower than in the standard treatment group, at the cost of a greatly amplified risk of severe hypoglycemia. The primary outcome, of course, a composite of CVD events, and I've called out the primary and death, but all of them were worse. Non-CKD better means CKD worse. So in fact, intensive glycemic control in patients with CKD not only is non-beneficial, it actually is harmful, which is what has led to recommendations from esteemed groups like the American Diabetes Association, and by the way, the EASD, that there are exceptions to the traditional goal of an A1C less than 7%. CKD is the sine qua non for a less stringent goal. Here the ADA says less than 8%. And I don't need to read this to you. These are all the key characteristics of patients with chronic kidney disease. Now, for the first time, though, we actually now have some hope on the horizon. Until October of 2018, the recommendations for glycemic control simply centered on an A1C or glycemic goal, irrespective of how that goal was achieved. For the first time, both the ADA and the EASD, at the EASD meeting, this was presented and now published in both Diabetes Care, in 2 publications in Diabetes Care and the ADA Standards of Care, to recommend either a GLP-1 receptor agonist or an SGLT2 inhibitor in certain categories of patients. They still recommend metformin be background therapy unless there's a contraindication or not tolerated, which will be the case for many people with CKD. But be that as it may, for patients with heart failure or chronic kidney disease, a preference for SGLT2. We heard a wonderful talk this morning about SGLT2 and heart failure. And we also heard about the GLP-1s yesterday and their value for treating atherosclerotic cardiovascular disease. Now codified in guidelines that these are preferred therapies. This is the first time we've seen this. I will also be showing you some data today that's really very recent and emerging, that these agents are also highly renal protective as well. But I don't want you to forget about metformin. In the US, we have not used a lot of metformin in CKD until the FDA label was changed about 2 years ago. But in the rest of the world, it was widely used, even in moderate to severe CKD. So these are GFRs less than 45. In this meta-analysis, note that metformin, when used in other parts of the world, actually has a survival benefit in and of itself. So don't forget about older agents that are inexpensive and easy to use, not only for glycemic control, but also for survival. Now, kind of like what you heard about heart failure, perhaps we were looking for love in all the wrong places when we were looking for new treatments for chronic kidney disease and diabetes. This is just a sampling from clinicaltrials.gov of different categories of agents under study. And the truth is that most of these have just not borne out to being effective treatments for chronic kidney disease, very parallel to what you heard about heart failure. But the love was right down here in the corner with the newer anti-hyperglycemic treatments. And I'm going to turn my attention now to SGLT2 and GLP-1. So again, as a centering point, I think this group is very familiar with the main results of EMPA-REG, which was one of the first cardiovascular outcome trials to report this remarkable benefit on the primary outcome, driven by a reduction in cardiovascular death and hospitalization for heart failure. But kidney outcomes were important secondary outcomes. And what that study, and now subsequent studies done with canagliflozin in the CANVAS trial, and with dapagliflozin in DAPA-CKD, or excuse me, in the DECLARE trial, all of these have shown the same thing. These agents decrease development of macroalbuminuria, reduce slope of GFR decline, prevent creatinine doubling in end-stage kidney disease, and importantly, the cardiovascular benefit that you heard about on heart failure and these kidney disease benefits hold up in the subgroups with and without pre-existing CKD. This is really important because remember, development of CKD is a larger risk for death than it is for end-stage kidney disease. We have a win with an agent that prevents death, prevents cardiovascular deaths, and allows among the living to live without progression of chronic kidney disease. If you will, this is the recipe that we wanted, which is stay alive and stay healthy. In the interest of time, I'm just going to show you examples from EMPA-REG, but virtually identical results have already been published from CANVAS and DECLARE. Incident or worsening nephropathy, this was mainly driven by reduction in albuminuria, but they also did a post-hoc renal composite, which is what we call the real deal, doubling of creatinine in end-stage kidney disease or death from kidney disease, and nearly a 50% reduction. And this has been shown in the 2 subsequent trials of secondary outcomes in the cardiovascular outcomes trials of approximately 50% reduction in hard endpoints. Now, the truth is that these agents do have effect on risk factors. They obviously lower blood glucose without an increased risk for hypoglycemia. And I think we heard yesterday about the hypoglycemia may be part of what's driving the cardiovascular risk. So the balance of what's the appropriate level of glycemic control could shift if the risks go down. They reduce blood pressure, they cause weight loss, and they cause a natriuresis. And we heard a lot about the sodium-hydrogen exchanger, which I'll talk a little bit more about. So there may be indirect effects of both classes of agents, but what I want to dial into are what was yesterday called the pleiotropic effects or the direct effects. So again, because you put nephrology in the name of this meeting, I thought I could take you back to renal physiology, go on a little deeper dive than we went on this morning. But this will really set the stage for our understanding of how this works. And one of the things, too, and I think this came out this morning, but I want to repeat this, is these findings were unexpected. So we're almost retrofitting the science to the clinical data. But be that as it may, the hyperfiltration hypothesis still lives. I cut my teeth on renal hemodynamics, so this actually warms my heart. But this is actually the nephron in the setting of diabetes. We see a dilated afferent or inflowing artery, a relatively constricted efferent, increased filtration of glucose, and in the proximal tubule, the SGLT2 receptor is a transporter that reabsorbs glucose and obligates sodium reabsorption. So in the setting of diabetes then, there's decreased distal delivery of sodium to an area of the distal convoluted tubule we call the macula densa. In this specialized area, there's about 5% of sodium reabsorption normally, and it goes down to probably less than 1% in diabetes. So there's decreased reabsorption of sodium, which is actually an active transport process on the basolateral side. That means the blood side, not the urine side. When sodium is reabsorbed by active transport, sodium-potassium ATPase generates adenosine. And adenosine, in a paracrine fashion, marches next door where it's a vasoconstrictor at the afferent arteriole. This so-called tubuloglomerular feedback is reduced or lost because in diabetes, there's decreased distal delivery of sodium. With the SGLT2 inhibitors, what happens is that we have blockage of the SGLT2 transporter. So that's how it works to lower glucose. People pee out more sugar. But when they pee out more sugar, they also increase urine sodium delivery to the distal convoluted tubule and to the macula densa, so that there's increased sodium reabsorption, adenosine generation, and then adenosine clamps down the afferent arteriole. In the clinical trials, almost all the patients were on renin-angiotensin system inhibitors, and that's important in terms of understanding these as well. because the constriction at the downstream end is largely under the control of angiotensin II. And the main hypothesis, the hemodynamic hypothesis for kidney protection in diabetes and other forms of kidney disease that are associated with hyperfiltration at a single nephron level, is that glomerulus is decompressed on the downstream end. Now we have the opportunity to also clamp down on the upstream end. So when I teach our medical students, I basically say in diabetes, it's like the faucet's turned on, there's a hose and it's kinked downstream. With an ACE inhibitor or A or B, we decompress the downstream end, and now with the SGLT2, we turn the faucet down and can truly normalize glomerular hemodynamics. And just for a centering point, in diabetes, the glomerular pressure is sometimes 60 to 70 millimeters of mercury, where it's normally about 40. So that is a huge pressure gradient that now we have the opportunity to much more effectively normalize by combining both upstream and downstream control of hemodynamics. So, is there any evidence for this? Well, really, all we have to do is turn to the estimated GFR from the EMPA-REG trial. When this was presented at the American Society of Nephrology, there was like a sigh in the audience because it was as if they'd read Brenner and Rector. It's exactly what you would predict for the hemodynamic hypothesis. With both doses of EMPA, an abrupt decline of about 5 millimeters of mercury, but stabilization over time with progressive GFR decline in the placebo group. So there may be other mechanisms, but this clearly is likely to be a major one. I can't talk about it because this trial is embargoed. It will be presented in Melbourne 6 days from now, on April 15th. Credence is a trial of Empagliflozin in patients with chronic kidney disease. Stage 3 is the lowest GFR. I believe it's stage GFRs of 30 to 90 with macroalbuminuria. But what we know, and this is the first time in my career that it's ever happened, is a kidney trial was stopped for efficacy. We've stopped trials for safety before. And I don't need to read this to you. This is the press release from July 16th. I'm pretty close to this study, and I'll just tell you the investigators call it overwhelming efficacy. The other thing that I've never seen, and maybe during the Q&A, if some of you have seen it, please tell me, is that about 2 weeks ago, the company that makes this drug has already filed with the FDA for a new indication before the data are in the public domain. That's new to me. And they're seeking an indication to reduce end-stage kidney disease, doubling of creatinine, which is a surrogate for this, and the big one, kidney or cardiovascular death. So stay tuned. It will be webcast. I'm going to watch it Pacific time, 3:30 Pacific time on Sunday. I believe it's presented at 9:30 a.m. in Melbourne, Australia. So I think this is going to be quite a cataclysmic shift for us. But how exciting to finally have something that works for these patients who are at such high risk. Okay, let's now turn to GLP-1 receptor agonists. We heard a beautiful talk by Dr. Drucker, and I'm glad that he told you so much about the science because I don't have time to go through it. I've made one summary slide. One thing I do want to dial into is this receptor issue. He showed us pictures of the receptor in the kidney on the afferent arteriole. I'll tell you, we also work in this space, as does this group in Japan. Now, these guys find it really everywhere. I've focused on the nephron. They've found them in several different types of mesangial cells and proximal tubular cells. Like Dan said, we can't find it in the glomerulus. We do find it in the proximal tubule. We've done 3 different mouse models, and we've looked at 10 human biopsies. And actually, we do find it in diabetic humans in the proximal tubule. So back to Dr. Packer's talk, this receptor, or GLP-1s actually block the sodium hydrogen exchanger NH3/2. So we would say that this is at least a biological rationale for how that could occur because it's in the right place and these agents do cause a natriuresis. So that's our hypothesis about how that works, Dr. Packer. But be that as it may, irrespective of where the receptors are, in now at least 6 different mouse models of type 1 and type 2, they do all the right things, reduce albuminuria and the structural changes of glomerulosclerosis. How do they work? They actually inhibit signals to oxidative stress and inflammation, including PKC beta NADPH oxidase. They increase CAMP, as you said, but in the kidney, it's actually protective because it's anti-inflammatory at that site. So it's going to be a balance, right? A balancing act between where the benefits are going to accrue and how, you know, for example, maybe natriuresis might outweigh the effect of CAMP on the heart. I don't know. But in any case, so far the data look good clinically, and then the markers of inflammation go down. And again, I have slides of all this at the end if you want to see it, but we're going to focus on the clinical data for the purpose of the main presentation. So again, a centering point, our cardiovascular outcome trials, the gifts that just keep on giving. This is from SUSTAIN 6, Semaglutide. You heard about this yesterday. Again, a strikingly positive effect on the primary outcome. But the components of the outcome are more in the atherosclerotic area, not in heart failure. And I won't repeat all that. Just as a centering point, then, what did we learn from these trials about the kidney? So now, across agents where it has been studied, leader, Dr. Hans Mann is here. He's the PI on this study. Semaglutide and dulaglutide, and Brian and I were co-PIs on Award 7. Has been shown consistently. In moderate to severe CKD, so this is now GFRs below 45, they reduce GFR decline, shown by Lira and Dula, and the cardiovascular safety holds up, and in fact, arguably might actually even be better in patients with CKD, as does the kidney safety. So again, Hans's paper here, there's a lot more depth to the paper, but what I want to dial into is the effect on GFR, since that is the causal pathway to kidney failure. And what you can see is it's actually in the group with low GFR where the drug is more effective at preserving kidney function. But the truth is, it's easier to show a difference in GFR decline when GFR is declining as opposed to the earlier groups. In the group with less than 45, or GFR less than 30, not statistically significant, but look how small the numbers are. It may be a power issue, but directionally it's going the same thing. But that takes us on into Award 7. Oh, excuse me, before I do that, another publication from Hans looking at the cardiovascular risk in patients with CKD. In the main paper, statistically significant interaction on the primary outcome by GFR with a larger benefit in the low GFR group. And then Hans published in Circulation in December that there was a graded risk reduction by lower GFR categories. That is, the lower the GFR, the larger the benefit. Whoa, that just knocked me out of the park. Kidney patients usually do worse with every kind of risk factor modification. They don't get as much benefit out of statins, antiplatelet agents. Now we have agents where they're at least as good, maybe better served by these agents in terms of cardiovascular risk reduction. That's huge because they're more likely to die than progress. So let's now walk into Award 7. Again, I want to call out Brian's role as a co-PI on this study. This is a kidney study. This is a study where we enrolled people with CKD stages 3 and 4, GFRs below 60, but you can see most of them had GFRs below 45, 75%. They almost all had albuminuria, and about 45% had macroalbuminuria, very high risk for GFR decline. That's what we selected them for. So this is not a CVOT. It is one of the very first kidney trials that selected patients for kidney disease, high risk for kidney outcomes. Here is the main data. This was an active comparator study, so it's not due to differences in glucose. I don't have time to show you the glucose levels were the same as were the blood pressure levels. So this is a direct, our view is it's a direct effect of the drug. So with insulin, you see the predictable decline in GFR of this group. They start off with a mean GFR of about here 35 by CKD epi, and both doses preserve GFR over time, shown in a bar graph at either 26 or 52 weeks. The insulin group, the predictable decline in GFR with no significant GFR loss in the dulaglutide treated groups. But where the money really is on outcomes. This paper is embargoed, but I presented this at ASN, so we'll show you the data here. a 50% reduction in 40% GFR decline, which is another proxy for end-stage kidney disease or end-stage kidney disease itself. What I'm not going to show you is even in CKD stage 4, GFR is below 30, 50% reduction in end-stage kidney disease. We have never seen an agent, as far as I know, you nephrologists speak up, at CKD stage 4 that prevents end-stage kidney disease. So, where do we go from here? To me, the new drugs for chronic kidney disease is like this Jackson Pollock painting. It is rather beautiful in its own way. I like it, but I don't know where I'm going. So I wanted to give you a vision of the future, how we're going to do even better than just randomly stumbling onto new drugs. This is another one of our papers. Rudy Solicic is the first author. She's one of our young faculty members who's very smart. And what we did was we actually looked at a series of kidney biopsies from humans with diabetic kidney disease who had CKD stage 3B, GFR 30 to 45 with macroalbuminuria. And we pulled kidney biopsies that had been done in these patients. They were clinical kidney biopsies, but be that as it may, this is a normal glomerulus for centering, for those of you who don't look at these all the time. This patient has mild mesangial expansion. This patient has more severe mesangial expansion with mesangiolisis. What you might remember are good old-fashioned Kimmel-Still-Wilson nodules. This is stained differently here to show you aneurysmal dilatation with Kimmel-Still-Wilson nodules, and this is global glomerulosclerosis. They would be staged clinically exactly the same way by eGFR and albuminuria. Now, if structure begets function, which it does, why would we think that these patients would respond to the same treatment? Maybe this person will do just fine on an ACE inhibitor, this person needs to be referred for transplant, and maybe this person would do really well with a GLP-1, and maybe this person who has aneurysmal dilatation would do better with an SGLT2. We don't know. And it's like the blind leading the blind. So we've also taken a foray into precision medicine, and this is work done between our laboratory and Matthias Kretzler and Chip Brocious at the University of Michigan, where we looked at, in an unbiased way, RNA-seq of a number of different mouse models, as well as a series of normal human and diabetic kidney biopsies that we have in a biobank. And what we found is that there was a particular pathway called JAK-STAT that was overexpressed in both human and mouse diabetic kidney disease. The RNAs correlated very closely with human histologic severity. And when Dr. Brocious overexpressed JAK2 in the podocyte, it actually humanized the mouse disease. Mice aren't great models of diabetic kidney disease. I think we heard yesterday they aren't great models for very much of anything. But what we could do is we could make mouse kidney disease look like human kidney disease with overexpressing JAK2 in a key glomerular cell of the podocyte. So we decided to see what might happen if we gave it to people. And we have another friend that we've worked with for years at Eli Lilly, and he basically looked at this data. This is just a simple correlation between JAK2 RNA and GFR, showing that there was correlations with function as well. And Matt Breyer at Lilly used to be at Vanderbilt, and we all kind of trained together. And so they had developed baricitinib actually for rheumatoid arthritis and for psoriasis. It's advertised on TV all the time now. And so Matt Breyer was able to get some funding to at least do a phase 2 study, which is shown here. We enrolled people with diabetic kidney disease, macroalbuminuria, GFR about 40, very similar to the AWARD 7 patients. And we did a dose-finding study for 6 months, and albuminuria was the main readout. And you can see in a dose-related fashion, if we hit JAK2, we were able to reduce albuminuria, which is a good phase 2 readout. The other really interesting thing was we did a 4-week washout, and when we withdrew the JAK2 inhibitor, we had sustained reduction in albuminuria. And for us nephrologists, that means non-hemodynamic, a structural effect. So we hope to be going further with that. We also are trying to develop a biomarker panel of downstream inflammatory mediators, particularly urine MCP1, serum amyloid A, which has sort of been a darling of cardiology for a while. But we're looking at it in the urine because we're looking at kidney upregulation. And actually, the urine SAA is a better readout for kidney disease. So I will stop there. There's so much more to say, but I think that's enough for now. So what I'd like you to take away is that intensive glycemic control still is a proven strategy for CKD prevention and early diabetes. But less stringent glycemic control is recommended once CKD develops due to the high risks and nominal, if any, benefit. It's an exciting time because we accidentally stumbled on two classes of agents, particularly SGLT2 inhibitors and GLP-1 receptor agonists, that reduce all of the markers of kidney disease, slow progression, and at least so far in the case of SGLT2, there's large trial outcome data coming very soon that I think may change even the labeling of the drug. But stay tuned for the GLP-1 receptor agonists because I think they're close on the heels. And then I think where we really need to go is really the precision approach. In the spirit of full disclosure, the US NIH has funded the Kidney Precision Medicine Project, and we at the University of Washington and our colleagues at Michigan are at the Federated Central Hub for the Kidney Precision Medicine Project. We will be doing protocol kidney biopsies in people across the stages of diabetes and diabetic kidney disease. Also, we're going to look at hypertensive kidney disease and acute kidney injury to identify the molecular signatures. The JAK-STAT story was really the pilot study for the Precision Medicine Project, where we'll be identifying biomarkers and targets that maybe will help us more clearly profile individual patients so we can really get to that goal of the right treatment, right patient, right time. Thank you very much.